So let's talk about the anatomy of the hip. The hip joint is a ball and socket joint. Have a model here. Unlike the shoulder, it's a very contained concentric joint and much more stable under normal circumstances than the shoulder. It's a deep socket. The socket is called the acetabulum. This is the femoral head, and the femoral head is covered with cartilage. Let me place this down for a moment. If we just focus on the proximal femur, we have the head, as I mentioned, the neck, and this is the subtrochanteric region, and this is the trochanteric region. The acetabulum is formed in utero. It starts about fourth week in utero, and then by the 30th week, it starts to develop. And I think that's a good starting spot because a lot of the problems that we see, or a number of the problems we see in the hip, really start that early. There's a condition called developmental dysplasia of the hip. It used to be referred to as congenital dysplasia of the hip, but we felt that there are more factors involved than any congenital ones in particular. Basically, what happens is if the hip is not concentrically reduced either late in stages of pregnancy or in early childhood, the first several months of life, in fact, the acetabulum will not form properly. So, for example, if the ball is shifted out of the socket, let's say due to positioning in utero where it's not completely in, the acetabulum will not form correctly. What that means is that after birth, if it's sitting outward, this deep socket will not form and it'll be quite shallow. That has major implications later in life because if it's not deep in the socket, it's sitting on the edge of the socket, which means there's greater pressure here, and that pressure can lead to mechanical overload and arthritis. So even conditions that happen much later in life can start quite early.
So a child that's breached, for example, during
Yes.
pregnancy, which one of our kids was breached, as soon as he was born, they immediately said he has hip dysplasia. He was in a brace for 9 months. He was in a splayed open brace for 9 months. And I remember sort of freaking out thinking, oh my God, he's never going to be able to do anything. And they're like, no, he'll be fine. Like, as long as
Right.
you keep him in this brace.
Right.
And he was in that brace 23 hours and 45 minutes a
Right.
day. He basically only came out of it for a bath. I mean, it was actually hell on my wife. But 9 months later, his hips were
Fine.
fine. That's kind of remarkable.
Right. So it's called a Pavlik harness, and it actually is quite comfortable for the child. You can put it on and take it off without much of a fuss, or no more fuss than normally. But we know that if the ball is not sitting in there in that socket, it will not form properly. So the harness keeps that positioning until the acetabulum forms properly. The exams that pediatricians do, we always check the hip, and we want to make sure that it's in the socket. I think going forward, a lot more physicians and orthopedic pediatric specialists are using ultrasound to better quantify that the hip is in the socket, because we really don't want to miss any dysplastic hips. If you have a dysplastic hip, you are going to get arthritis. Now, it doesn't mean it's going to be symptomatic necessarily. It doesn't mean you're going to need a hip replacement, but people who have dysplastic hips, that is an acetabulum that did not form properly, are going to get arthritis. It's a mechanical problem where the forces are unevenly distributed across that ball, and there's edge loading, and that will break down over time, no matter what you do.
Do we have a sense of what the incidence is of congenital dysplasia, or whatever the new
Yeah,
name is?
developmental dysplasia of the hip. I don't, I, as far as
How many
numbers.
children born, or for
Oh,
every,
right.
1,000 kids that are
I think
born?
it's about 1 in 1,000. I think I might be wrong. I would need to check on those numbers. But the important part is that we shouldn't miss any. And if we're basing it solely on an exam, I think we're going to miss more than if we base it on ultrasound. And the ultrasound is really not that hard to do and certainly teachable. But that confirms that the ball is in the socket and the socket is healing properly. There was a study once done many, many years ago where it was an animal study, and they put a cube-shaped object in the acetabulum, and the acetabulum formed in the shape of a cube. It is going to develop based on what is sitting in that area. And if you wait too long, what happens is the soft tissue deep in the socket will become hypertrophied, and it's harder to get in. So I have patients that I've seen who they come in to see me because their hip hurts. They're 28, 29 years old, never had a problem before, did not suspect anything wrong, and we get an x-ray of the hip and they have arthritis. And it's quite a shocking development because you don't know. You don't necessarily know.
And for folks just listening,
Mm-hmm.
the plain x-ray is a good enough tool for that diagnosis because you'll see the absence or thinning of cartilage where you should see it, as in that diagram there.
Correct. So for arthritis that becomes symptomatic, we can usually see that. There obviously is a spectrum where the process starts to happen before we're even clinically aware of it. And, I think that's the future. That's the trick, is to find out before someone has clinical arthritis, do we know about it, and what can we do to avoid it? And I also think it's important to really discuss what arthritis is, because I know just from my own patients, I say you have arthritis, and there's a lot of conversation of what actually does that mean. The ends of all long bones have cartilage at the end. It's a layer, it's a very smooth layer, and the only reason joints move pain-free without friction is because of that cartilage. The coefficient of friction of cartilage is so smooth, it's smoother than ice on ice. There's no man-made substance. I mean, it's smoother than Teflon.
Wow.
And it's a biologic substance. It is constantly remodeling, albeit slow, but it is a biologic tissue that can adjust to the pressures. So part of arthritis is the loss of that cartilage. The cartilage starts to thin. The chondrocytes, which are the main is the cell of cartilage. Its job is to create proteins to make the extracellular matrix so that it remains healthy. But chondrocytes, the cartilage itself is avascular. It gets its nutrition through diffusion from joints, and they're not very efficient at making the extracellular matrix, which is imperative. So if there is if there's overload of the cartilage, the chondrocytes will respond, and sometimes they die. Sometimes they go into senescence. And cartilage, if you take the knee, for example, 2% of the cartilage is chondrocytes. And they don't have a lot of leeway when the load is substantial.
So when a person comes to your office and they're complaining of hip pain, what is, the most, I don't know, call it the three most likely sources of that pain? And obviously we'll go through some of the examination so people can sort of see how you will go about gathering that information.
Sure.
But what would be the top three most common diagnoses you'll encounter for a person with hip pain? And let's maybe bracket this by saying a person under 50.
Okay, sure. So, someone comes in with hip pain, right away I'm sort of thinking about the different layers of the hip. So in my mind, I'm thinking, is this a bone problem? Is it a bone cartilage problem? Is it a connective tissue problem, that is a ligament problem? Is the capsule too loose? Because the ball is held in the socket by a capsular layer. Or is it a muscle and tendon problem? So we from deep to superficial, we have bone, cartilage, and then we have connective tissue, ligaments, capsule, and then we have muscle, tendon. And then we also have to recognize that sometimes hip pain is referred pain. That is, it could be coming from your back. So we're thinking about those separate layers. And then we're also thinking about location. So someone who has pain in the front of the knee, the front of the hip is different than someone's side of the hip, back of the hip. So we need to tease all those factors out. So someone under the age of 50, would not necessarily be thinking about arthritis, but it obviously is always on your mind. And finding out a clue to what the diagnosis often depends on when it hurts, where it hurts, and what their activity is. So, for example, I think about patients, they come in, they say, we have the endurance athlete, we have the power athlete, we have the
non-athlete,
the
presumably.
non-athlete, the individual who is flexible, gymnasts, ballet dancers. They sort of have different patterns of hip problems. If we start with the endurance athlete, let's start there. Endurance athletes, is we start deep down in the joint. The first thing we have to rule out is that this is not a stress fracture. Stress fractures can happen in a lot of different areas in the lower extremity, and we separate them out as to high-risk stress fractures and low-risk stress fractures.
Risk of bad consequence if not treated?
Correct. So if someone comes in and they have a marathon coming up and they say my hip hurts, we have to make sure that this is not a stress fracture. Femoral neck stress fractures.
So just differentiate a stress fracture from a fracture.
Sure. So a stress fracture is something that occurs slowly. So a stress fracture at baseline, potentially normal bone with a substantial load to that bone that is in excess of what the normal healing capacity is of that bone. That is, bone constantly remodels. Every time we put stress on it, the microarchitecture is changing. There's small, tiny microfractures that occur from normal weight bearing. The body is very capable of adjusting to that load and making new bone. When you start exercising or working out or running, the bone will get stronger based on the stresses that bone sees. So for runners, for example, if you are training properly, there's no reason to expect that bone can't adjust to the increased load that it's seeing. But oftentimes, due to overtraining, where you're not giving that bone enough of a chance to heal, you develop these tiny little microfractures that aren't given enough time to then heal, and then it gets compounded when you go run the next day and the next day, and you're increasing not only the number of times that you run, but you're increasing the distance and the speed all at the same time. You get groin pain, because that's where stress fractures of the femoral neck hurt. Right away, we know we need to rule it out. And they tend to occur in the femoral neck, and we have two locations. Either this is called the compression side and this is called the tension side of the neck. And tension-sided fractures, where you get a little crack in the bone here, are much more severe than compression side. But the bottom line is that we need to know that this exists.
And the patient will feel groin pain, which is otherwise difficult for them to differentiate. I mean, they're not going to come in and say, my femoral neck hurts.
Correct.
It's what is the actual feeling? Does it feel akin to what you would feel if you pulled a muscle in your groin?
It does, except it's very weight-bearing dependent. So most people who come and say, I think I tore a muscle, I think I have a muscle strain. I don't see a lot of muscle strains in runners without an injury, right? You run, you're training, you're not necessarily going to get an acute injury like that. So sort of the presentation is slightly different. But it hurts in the groin, and right away you don't let them run until you find out if it's a stress fracture. And here's why.
And the MRI is the gold standard?
It is. So x-rays, we always need to get x-rays to make sure you're making sure that the joint looks healthy. There are other conditions that can cause groin pain, but it's usually negative. It's usually hard to detect a stress fracture right when the pain starts. The MRI is the gold standard to see that. It used to be bone scan, but that is impractical. And an MRI really is excellent at looking, because you can see the architecture of the bone, and you can see basically what we call edema in the bone, or a bone marrow lesion, and sometimes a crack in the bone. And it's graded. There's stress reactions, and then there's stress fracture. A stress reaction is like a pre-stress fracture. And the reason why it's a high risk stress fracture as opposed to a low risk is if it becomes a complete fracture, which was the other part of your question, what's a complete fracture? It's where this completely separates from the ball. And that's very important in this area because the blood supply to the head comes from this direction. So all of the nutrients that the ball sees comes from this direction. If this breaks and the blood supply is disrupted and that's not corrected quickly, then the bone in that area no longer has blood supply. It will die and can't support the cartilage anymore. The
Like
cartilage will
vascular
collapse
necrosis.
and you get AVN of the head, and that is a hip replacement, which is obviously difficult for anybody, but for someone who's in their 20s, 30s, 40s,
So the treatment for this when you make the diagnosis is rest.
is rest, typically. So if it's on the compression side, this is the compression side, you can go on crutches until you start to have no pain with weight bearing. Once you have no pain with weight bearing, you can continue along that path. Takes 6 to 8 weeks to heal, and then you can slowly start up your exercises to regain some of your endurance, physical therapy, etc. And oftentimes I'll get a follow-up MRI to make sure that it is healing and not increasing. If the stress fracture is on the tension side, the other, because you can imagine if it starts to crack on this side and the whole weight of your body is coming down this way, it can more likely displace mechanically. That often will need to get surgery, which is to put pins in, and we will often just put 3 pins from here to here into the femoral head, and it will heal, and they heal quickly. And oftentimes you can let that individual bear weight sooner.
So paradoxically, the riskier stress fracture usually has the quicker recovery because they go to surgery as opposed to
The tension-sided stress fracture, it just means you can often end up getting walking around doing what you need to do in your normal life too. I've had patients with compression-sided stress fractures who are having so much difficulty with just their getting onto the subway, getting to work with the crutches, that they wanted to have the surgery so that they can do that.
Are there any differences in hip injuries between men and women? I mean, one thing that stands out to me, just having taken care of a number of patients, is I always, again, at least in the under 50 population, it seems that far more female patients of mine have had hip issues than male patients. I've had a number of females who have had hip resurfacing, labral repairs. Again, these are all young women, so they're typically in
Right.
their 40s. Is that just a small number issue, and that's actually not a disproportionate finding? Or do women, based on the anatomy of their pelvis, are they more susceptible to labral tears or other types of injuries in the hip?
There are different patterns. There are certain conditions of ligamentous laxity that are more prevalent in women. Developmental dysplasia is more prominent, more prevalent in women, and so sometimes is the inciting issue. There are other types of hip problems that are more prevalent in men. There's a condition that we often have to treat that has implications to a lot of the structures around the hip. It's called femoral acetabular impingement. Femoral acetabular impingement is, we think, at least the prevailing theory is, let me tell you what it is first. Basically, on the neck, right around here, it's actually sort of in the front, a bump develops. So if I look at the model, a model here of the femoral neck, and there's sort of one here, and this is typically the location of it, and I'll just color it. You get a prominent bump of bone. So this area, it's called a cam lesion. And what happens is it changes the shape of at the head and neck junction. So it's not really spherical. It's sort of this oblong shape, so that when it goes into the acetabulum, it can pinch on the acetabular rim. And on the acetabular rim is not only the cartilage, but the labrum. Let me show a picture. So if we open up the hip and we look inside, again, here's the cartilage, this blue hue, and this lining is called the labrum. So if the ball is no longer spherical but oblong, the cam lesion will pinch on the labrum, and the labrum will tear and will injure the cartilage that is connected to that area. So how does this happen? We think it happens because the growth plate, which closes in males late teens, slightly earlier in females, because of repetitive stress from certain sporting activities, hockey, football, basketball, if there's impingement because of those high stress sports, that growth plate will have a delayed closure. And it will close later and a new bone will form in that area. And that's important because one of the risks of FAI that continues is you can get arthritis, because if the cartilage is being injured, then the increases the risk of needing a procedure later in life. So it's more common. That's more common in men, FAI. It's certainly prevalent in women too, not as. Sometimes it's different sports, but I think it's because the growth plate closes a little earlier in women that it may not be as much of an issue. It also may be the type of sport. The power type sport, where there's a lot of ground reaction force when you land, tends to make this situation worse.
Now, in the shoulder, the labrum creates effectively the socket. So if you have a person who's never had a subluxation of their shoulder, that labrum is creating kind of a vacuum around the glenoid head. This seems to be a much more stable ball and socket than the shoulder. What is the role of the labrum in stabilizing that joint? I can understand how asymmetries can cause arthritis, but just in terms of pure stability,
Right.
You don't really hear about dislocations of the hip very often. Obviously, the most famous example I can think of is Bo Jackson,
Right.
Which maybe we can talk about that case a bit. But what is it that the labrum is doing from a stability standpoint, or is it simply just providing a clean and neutral articulating surface for the cartilage?
It also helps to create a seal around the ball. So it is sort of a suction effect too. And it's very similar to the shoulder. We have dynamic stabilizers in the hip. It becomes more of a concern when the hip isn't formed normally.
Because then that acetabulum becomes flatter, which actually mimics the shoulder a little bit in terms of lack of stability.
Correct. And some of those patients who have instability of the hip because maybe they have some dysplasia, so the ball never really is in the hip, they have greater motion. I mean, ballet dancers would be a perfect example of that.
But it comes at the cost of less stability.
That's right. And some of those individuals actually have a hypertrophic labrum. It actually gets bigger because it's being asked to do more.
Yeah.
There's also, I mean, you can see in the picture here, there's a ligamentum teres. I don't know if you remember that from medical school.
Only slightly.
It's basically called the round ligament, and we didn't think it did that much. It provides some blood supply early on in life, and then later on doesn't really provide much blood. But for people who are unstable, this provides a secondary restraint because the ligament connects the ball to the socket. So one thing we need to be aware of whenever you're operating on the hip is to leave that alone in individuals who are unstable, because it's providing a bit of stability to that area.
Got it. Is this a good diagram to show how you do a total hip replacement or a hip resurfacing, or explain what some of those procedures look like?
Sure. So in a hip replacement, basically you're taking off the neck, you're cutting this off, you're inserting a metal stem down the shaft of the proximal femur. And then in this area, you're putting a metal cup in that region. And then the cup, there's different ways to do this, but the metal cup then has a plastic liner on the inside.
And is that still made out of ultra high molecular weight polyethylene?
Yes. Yes.
It's amazing. That's what they were doing 25 years ago. Why has that operation become so tolerable compared to the version of that operation I saw in medical school? Uh, Today, it's an outpatient surgery. The
Right.
people go home. They seem to recover so well. People used to be debilitated by that operation 30 years ago.
Right. So a lot of the approaches are different now. And honestly, in every aspect of the surgery, technology has helped us. So back when I was training as a resident, almost all of the hip replacements were done through a posterior approach, an approach through the back muscles,
So which muscles were actually getting cut,
through the gluteus muscles.
which are huge?
Right. And now you go anteriorly. Now I don't perform, it's not one of the surgeries that I perform hip replacements, but it's much easier to spare the muscle and the ligaments when you do an anterior approach that is an approach from the front.
So you're
It's
saying
also,
less of the morbidity is due to less muscular damage on the approach?
it
Yeah.
is, it is. And also just the way we medically manage patients around the surgery. We give medicine to decrease blood loss, and so the whole process has become much more efficient and safer, to be honest.
And a resurfacing leaves the femoral head intact and only addresses the acetabulum?
No,
It's the opposite.
yes,
Okay.
yes. And I don't do this, so I can't really, I'm not going to speak to the different intricacies of that. Um, but there are ways to preserve the amount of bone that you're taking if the individual is young. I think that's done less now, actually, of late.
So we talked a little bit about what are kind of the problems that people will show up with when they're young. When people are seeing an orthopedic surgeon north of 60, 65, I'm guessing it's arthritis and fracture that would be the dominant
Right.
injuries. Is there anything else that's showing up as significant?
Yes. So, in addition to those problems, we also see muscle and tendon problems. In particular, we see issues with the tendons on the side of the hip, and this is actually not just in older individuals, but all individuals. The main abductor of the hip is the gluteus medius, which you could sort of you could see coming out. It sits on the back of the pelvis and attaches at the edge on the lateral or the outsides of the femur. And these muscles help to,
Is that glute med and min?
yes, correct.
Yeah. And glute max is not shown here.
Correct. The glute max comes across here and attaches a little bit lower down on the femur, and that's not depicted here. So this muscle is incredibly important. In fact, we consider this to be the rotator cuff of the hip.
Just those two.
Just those two, correct. The gluteus medius and the gluteus minimus. And it has a very similar profile. And just as in the rotator cuff, it starts to degenerate after a certain age, same thing happens in the hip. Weakness of the gluteus medius is very difficult because it's incredibly painful. It doesn't have great healing potential. We also see this in endurance athletes as well from the repetitive stress. And we also see this in unstable patients because those muscles are trying to dynamically keep the ball in the socket, so they are working harder. Ballet dancers in particular have incredibly large gluteus medius minimus, powerful. Part of the reason is because they're asked to do a lot to stabilize the hip. So we see tears there all the time, and we often approach that just like a rotator cuff.
So are most of the injuries you see here underuse or overuse? It sounds like they're mostly underuse.
I don't think so. I think it depends. So the older we get, it doesn't necessarily matter whether it's overuse or underuse. These things will happen because that is just the normal trajectory of tendon problems, tendon pathology. The tendon cells over time start to degenerate just like all of our cells, and they go through process of senescence like all tissue. And those senescent cells produce those factors that lead to degeneration of the tendon, causes inflammation, incredible amount of pain, and it's hard to treat. It's hard to reverse the process. Now, If you knew it was happening before it started, would you be able to do anything? We don't have that ability yet, but that's what we're trying to figure out, how to intervene before these injuries take place.
There's two things that jump into my mind here. The first is the obvious need for, I hate to use the word physical therapy because that really gets misconstrued a lot, but basically deliberate exercise that strengthens those muscles. I mean, when I used to be a cyclist, um, one of the challenges of that versus any sport truly is you're sort of in one plane, one dimension, right? So you get very, very strong quads, glutes, and hams. Your glute med and min do very little. You're not really doing any abduction of the hip. And as such, you get a very tight tensor fasciae lata. A lot of cyclists get really bad IT band pain because they just lack that strength there. And so an obvious way to fix this, which I was very lucky that I was able to fix this non-surgically because I was having debilitating IT band pain, was simply doing a lot of strengthening for the hip abductors. So that at least suggested to me that you could be preventive in some way.
If I had any muscle that needed to be worked on and I had to pick one muscle group, it would be that muscle group, starting from early teens.
Mm-hmm.
It is implicated in so many lower extremity injuries at the hip and the knee. A weak gluteus medius, weak abductors um, can cause a lot of injury. And I do believe that the stronger they are, it's almost like bones. The higher the bone density you get early on,
Yep.
then
The higher your glider, the
that's right.
longer it
That's right.
rides. Yeah.
Because it's going to degenerate. It is just going to happen. And so the stronger and healthier the tendon is at a starting point, this is sort of how I think about this. First of all, not only are you likely to have less injury, and I'm talking about ACL injuries too, I'm talking about
Knee injury, it holds back the valgus,
yes,
everything that we're going to talk
exactly,
about in the knee.
exactly. Hip fractures, which we started to talk about a little in the elderly, that too. These muscles are incredibly strong, and the hip flexors too. There was a study done out of South Korea that looked. It was an imperfect study, but it was pretty decent. They took a group of, I think it was retrospectively evaluated, but they took CAT scans of people who were in for a hip fracture, a femoral neck fracture, elderly population, and they measured the volume of their psoas muscles. So this is the psoas muscle, and this is the iliacus. Together they make the iliopsoas muscle, attaches here.
And this is what picks your leg up.
That's what lifts your leg up. So if you stumble, you pick your leg up to save yourself. The volume of that muscle was significantly smaller than that of an aged matched control group who were getting CAT scans for other reasons. Now, we don't know why they were getting CAT scans, so that's, it's a little bit confounding, but it showed that there was a significant decrease in volume in those patients who have hip fractures. So we know that hip muscle strength, so the important to get the abductors strong, the hip flexors strong. The adductors, the problem with the hip flexors is that we're always sitting. So even if they're strong, they're often tight because we're always in this position. So it's important to see how your hip flexors are, make sure that they're flexible, because an imbalance in the flexibility of that muscle group will also impact the antagonistic muscles in the back, the gluteus maximus, which extend the hip, and the hamstrings, which also extend the hip. So these are, it's fine balance. But if I could work on anything to help prevent these things later, I think this is a good place to start.
The other thing that I've really migrated to over the past decade as I've become very obsessed with all of these muscles, in particular those hip adductors, is the importance of training them not just in concentric phase, but also eccentrically. So there are these exercises we do in a training, I don't know, for lack of a better word, philosophy, dynamic neuromuscular stabilization, DNS. There's a position called DNS star. I was just doing it this morning. So I'm doing this stuff most days. And you're laying on your side So if I'm on my right side, my right elbow is down. It's sort of like a plank, but you're on the knee and your hips are up and you're extending yourself forward as you're putting the hip back. So you are eccentrically loading the adductor as you go back, and then you're concentrically loading it as you bring yourself back up. Now, for anybody who's done this, and we've demonstrated these things in other exercise videos, I mean, 5 reps of this slowly, you feel like someone is jamming an ice pick into those muscles. It is remarkable how difficult it is. But you don't need to do a lot. I mean,
Right.
just doing a little bit of
Right.
that stuff every day
Right.
does so much in terms of lower body maintenance.
Right.
And looking at this picture, I think it's pretty clear why. It's such small muscles that have such an unfavorable angle at their attachment, right? In terms of
Yes.
like the contraction is, it has such an unfavorable lever arm for what it needs to do. So it really has to be strong.
Right. Right.
Let's talk a little bit about fractures. So I guess let's put aside just kind of the 25-year-old skiing accident, freak accident. It's like
Right.
you're going to see that all day long. But let's talk about the more predictable and far more catastrophic fractures to quality of life, which
Sure.
are these fractures of the femoral neck that are occurring in people due to osteoporosis and osteopenia. Now, I talk about these stats all the time, and nobody believes them because they're
Right.
so absurd. But
Right.
if you're 65 or older and you fracture that hip, depending on the study, 15 to 30% 1-year mortality.
Right.
Can you explain why that is? Like, how do these people present to you, and why is it so
Right.
challenging to take care of that fracture?
I think part of a large percentage of those people, it's usually another disease that has overtaken their lives. And so they may have advanced stage cancer, they may have advanced renal disease, and it's almost the last
It's the
event
last
then.
straw.
It's
Yeah.
the last straw.
The
So
hospitalization alone is just
that's right.
catastrophic.
That's right. And so it's very hard to when you're elderly and you don't, first of all, you break your hip, you come to the hospital, there has to be some medical management to make sure that it's safe to proceed with surgery. And everybody who has a hip fracture needs surgery. You can't treat this non-operatively. It would be essentially a death sentence to do so. Because the goal is to mobilize as quickly as possible. Because for even the people who don't have, the mortality of 20 to 30% within the first year, that's been a stable number for decades. I mean, every time they look at it, that's a stable number, and that's within 1 year. So our goal is to get you up.
And Adam, how much of that is really acute? It's pulmonary emboli, fat emboli, MI because of surgery versus, 2 weeks out, they're
Yeah,
okay, but then they fail to thrive and they die within the year.
it really is spread out. And the management of these patients is very important early on. So we like to get a full team on board, right? A geriatric specialist. You need a team approach because you need them medically optimized before surgery so that they could safely go through the
How long
surgery.
can they take to get tuned up before surgery?
So it should be done within 48 hours.
Wow.
Before we had the medical management sort of model of hip fractures, you oftentimes were able to get the surgery done quicker. An orthopedist comes in, say, let's just do this right now. Everybody signs off. We have to do this. Let's go. When we have sort of the team approach, the medical doctor's like, listen, we have to get an echo. We have to do these other things. We need to make sure the bloods are okay. That has delayed the surgery slightly.
But probably gives better outcomes
It doesn't.
perioperatively?
It has, at least in the studies that I've seen, people are able to get discharged sooner, which is a good thing.
But their long-term outcome
It
is
still
just
seems to be about 20%.
wow.
And part of the issue is, first of all, obviously you broke your hip, so there's a good chance you're weak. Your NPO, right? The first day you come in, no one will feed you anything, right? You don't get a meal.
Yep.
And then in bed for 2 days, we have surgery, in
Yeah,
bed
you're
for a
probably
week.
getting dehydrated and yeah.
It's just, and then even for the people who don't who don't pass away, who don't die, there's a decrease, about 50% lose a level of function. So if you were using a cane before, you're using a walker. If you're using a walker before, you're now in a wheelchair.
If you were walking normally, you might be using a cane. So there's a
Exactly.
50% of people
Right.
that go down a level in performance.
I once had a patient who it was early on in my career. I was a junior attending, and a resident calls me and says to me, we have a patient with a femoral neck fracture, and he says, so tell me the story. He says, well, he's 40 years old. He was riding on the West Side Highway, and he crashed and he broke his femoral neck. I said, well, I'm coming in now. Let's fix this right away. So I said, just go consent him for the surgery, in which the resident was a junior resident. He goes and talks to the patient about all the risks and benefits of the surgery. And I go in to see the patient, and he's got this, like, obviously I expect him to be miserable, but he really was like, and I explained, and he said to me, he says, your resident just told me I have a 30% chance of dying this year.
He kind of forgot to age
Yeah,
adjust that.
yeah. I
Yeah,
said, well, don't worry, you're not going to die. Somebody else is, but not you,
yeah.
the resident.
Um, what is it about the hip? Well, let me reframe my question. As you were talking earlier about sort of the degeneration of the hip, obviously the first thing that comes to my mind, and I'm sure everybody's mind listening to this, is where do stem cells play a role here? Now, we're going to
Sure.
talk about stem cells through all of these joints, but we might as well start here. When I hear that the tendons of those muscles and those muscles themselves are going to weaken, when I hear that my cartilage is going to weaken, when I hear that the osseous structure of the bone is going to weaken, all of these things make me wish I could just have newer and younger cells there.
Right.
So what do we know about the utility of stem cell therapy here? What's the state of the art today?
Right. So, this is a great conversation, and there's a lot of layers to this conversation, because there's, the dark side and the bright side of this. When we talk about orthobiologics, or biologics in general, basically biologics, it's a class of therapies that are using your own natural resources to promote healing. So you're using a biologic product to encourage healing of diseased or injured tissue. So the most commonly used ones are blood, specifically platelets, bone marrow aspirate concentrate is called, and also fat. So if we sort of go through those three, just to start there, for PRP, what are we doing? So we take your
Platelet-rich plasma.
platelet-rich plasma. We take your blood, we draw it, and we take it down the hall, and we spin it in a centrifuge. And the centrifuge machine will separate out the different elements of the blood based on the density of those elements. So after you're done spinning it, you have a layer called the plasma layer, which is rich in plasma and platelets, and it separates out the red blood cells and a lot of the white blood cells. Now you could spin it twice. You could do two-spin technique. You can spin it so that you're keeping some of the white blood cells. So we've categorized it into leukocyte-rich PRP and leukocyte-poor PRP. And this is a very simplified way that we think about it right now. And there's certainly, if we fast forward 10 years from now, this will be a ridiculous conversation, because we just are sort of in our infancy of understanding what we're doing here. So the principle is we take those platelets, which are involved in healing. We know this because if you cut yourself, the first thing that happens is the platelets come to the surface to form a blood clot and to form a scar, and then you heal. So platelets are associated with an incredible amount of growth factors and healing factors, including the 800 to 1,000 proteins within the plasma. And you inject that into tendon, a joint with arthritis, muscle, and see what happens. So the problem is that as a physician, you are allowed to do that procedure. right? So there's no rule that can't say that anybody comes in and they say, I have this injury, can I have stem cells? And you say, oh, sure, let me give you PRP, and I spin it and I inject it. So, but what does the actual science say about what's actually working? And what we've learned is that it works for some things pretty decently and other things not well at all. And we can only go by our randomized controlled trials and systematic reviews of randomized controlled trials to find out what seems to work.
So what are those best case scenarios?
So tennis elbow seems to work with PRP. There's good data to suggest, like tier 1 data, maybe tier 2 data that suggests that it works for tennis elbow. It works pretty decently for gluteus medius tears. And for tendons, that's about it. Some will argue maybe in the hamstring tendon it works, but I'm not convinced.
And just to be sure, are you talking specifically about PRP, or are you talking about the broader umbrella of stem cells?
Broader umbrella of stem cells don't seem to work. And I think it's important to bring up a very important part, which is these aren't stem cells. And I think that's one of the major problems, is that there is no stem cell therapy anywhere unless...
So when you go to Mexico and get stem cell therapy, what are you actually getting?
I don't know, but they're not stem cells. I mean, the only stem cell, I mean, I can only speak what's happening in the United States, but the only stem cell therapies approved in the United States are for leukemia, blood disorders, blood diseases. There is no stem cell. In fact, the FDA has a big warning page with a video that explains there are no stem cells. Stem cells implies that I'm going to inject cells into you, and those cells are pluripotent. They have the ability to become something else. And those cells are now going to become your cartilage. They're now going to become your tendon. That doesn't happen. In fact, right now, what seems to be happening...
What's the identity of the stem cell? In other words, what is the signature that allows that doctor to know, or at least believe, they have a stem cell? Because these are not autologous typically at these clinics, right? Aren't they?
Are we talking about Mexico or...
I only say that because everybody I know is basically going abroad. Although I know some people that have done this here. They tear the rotator cuff, and they go and get stem cells injected, and 6 months later the rotator cuff is fine without surgery.
Right.
Sort of that type of anecdote.
So yeah, that first of all, it's illegal to actually give stem cells. So a few years ago, people were able to get products that were manufactured by companies who were selling umbilical cord blood or some derivative of umbilical cord, some umbilical product as stem cells. Wharton's jelly, some of it's called, exosomes. All these things are not allowed. The FDA will not let you inject this into anybody. So
what's the reason for that?
So the FDA has a division that regulates the use of human cells, tissues, and products.
Even if autologous, even if they're your own?
You can use your own as long as it's not manipulated, or what we considered minimally manipulated.
So spinning is not a manipulation.
Spinning, that's right. So you can take your bone marrow out of the pelvis, and we get it from the pelvis, and you can concentrate that. But you can't give any enzymes to it. You can't digest it. You can't make any changes to that product. You can only give it as is. Now with fat, because fat has actually shown some promise with osteoarthritis of the ankle, very, very good studies on ankle osteoarthritis and fat injection, same with knee. You can do that because you're minimally manipulating the fat. You are taking it and making it into smaller fat particles, but you are not essentially altering the fat itself.
And you're basically breaking down adipose tissue into individual fat cells?
It's micronized. It's called micronized. It's micronized fat.
And the idea is that micronized fat regrows as cartilage?
No. Still doesn't.
What does it grow as?
So that's what we don't know. So right now, our best understanding of biologics in reality is that it reduces symptoms. It is symptom modifying treatment. And it's a good symptom modifying treatment when it works, because we don't have a lot for, let's say, arthritis, tendon problems. Our toolbox of things to use when someone comes in with knee arthritis or hip arthritis are pretty pathetic. It's, you know, you're going to go to PT because that's been shown to help. I'll give you a brace, maybe that might help. Maybe take some COX-2 inhibitor anti-inflammatories and some, cream, right? We don't have, like, the repertoire of what I prescribe is pretty
The
pathetic.
non-surgical treatment for
Right,
these things is pretty
right.
weak.
So here's an opportunity with the biologic field to reduce symptoms in a safer way than, let's say, cortisone. Because cortisone is quite effective and safe as long as you're not, injecting over and over again. So there's a space for this that is very reasonable, and the randomized controlled trials show that it works for knee arthritis probably better than anything. But the bigger, I think, if we like looking forward as to what we're going
why
to
don't we
do,
have bigger, or why don't we have RCTs that can
right?
answer these questions definitively? Because there are a few things that I discuss with people in medicine that create more, um, you know, sort of polarization around treatment than the use of these biologic therapies, where, the people who have had these procedures will swear up and down by them when they work, which is,
Right,
you don't understand. Like, I couldn't move my arm, and in 6 months I was fine. Of course, we always fail to have the counterfactual here, which is it's
correct,
possible your arm was just going to get better on its own.
correct,
It's possible that the initial, MRI showed something, but the follow-up MRI didn't show something, or it just healed on its own because it was going to heal
correct,
on its own. So,
correct,
the only way you can ever escape that is with randomized
right.
controlled trials. Are they being done?
Yes. And so, to that point, if we inject saline into somebody's joint, a number of those patients are going to get better. So that's sort of the standard we use. How does PRP work in comparison to saline? And there are a lot of studies. There are dozens of studies, randomized controlled trials looking at PRP. And many of them have excellent results. The problem
And that's, for example, tennis elbow.
for knee arthritis,
For knee
particularly,
arthritis,
yeah,
okay.
that's probably, of all the data, that's the tier 1 best data.
Got it.
But we know so little about this because it doesn't seem to work well in hip arthritis.
And why do you think that would be? Is it just possible that the studies haven't been done correctly?
Maybe, and I think brings up a very important point. When you do a randomized controlled trial, let's say for a medicine, a hypertensive medication, you know what dose you're giving, right? And you're comparing it to some other treatment where you know the dose. Platelet-rich plasma, I'm taking your platelets of unknown concentration,
Of unknown quality.
I'm spinning it in a machine either once or twice, and different machines concentrate those platelets differently. And so then I end up with a product with a certain amount of platelets, and then I inject it back into you. I don't even know your disease process specifically.
Yeah.
So when you put people into a large number into these studies, you get a lot of crappy data. So what the future holds is, and there's a push in our industry, and there's a particular association called the Biologic Association, which is like an association of associations internationally, where they've formed something called the BARB, which is a Biologic Association registry and it's a bioregistry. It's a registry and a bioregistry. That is, they have lots of centers and they want to know everything about what you're injecting. They want to know what's the concentration of the blood of the patient.
And what percentage of docs who are regularly giving this therapy are participating in the registry to the point where we can generate information?
Very, compared to the total amount, very few, but it's enough people that we can get really good data to find out what's the dose, what's the critical dose of platelets that we need to affect change. And other things, we can do a proteomic analysis of the actual fluid itself. And you match that with outcomes data from the registry. So you have a biorepository and a registry combined. Who did well and what did they get? And they save samples of that stuff
But at
too.
best, this can only inform what an RCT should do. Those data by themselves don't tell us anything, right?
Correct. But this gives information about to actually lead to the trial,
Yeah.
right? So you say, okay, it looks like this works. Let's try this particular dose.
So right now, PRP looks more effective at reducing symptoms than cortisone in the knee for arthritis. Is there any reason to believe it can delay the requirement for total knee replacement?
So maybe we know that if we look over the course of a year, because this is what those trials looked at, cortisone works very well in a short time frame. It's pretty impressive. The first couple of weeks you get one and it helps. There are some people who the pain comes right back, so it doesn't have staying power. When you compared steroids to PRP, the PRP, if you look out over a year, they're doing better. Hyaluronic acid, which is another thing we inject, also is doing better than cortisone if you look out. If you combine...
Now, isn't hyaluronic acid considered biologic?
It's not.
Because it's an FDA-approved product?
Yes, and I don't even know that it's a drug. I think it's even classified differently like a device, but I'm not 100% clear on that. So there's a number of studies, or I don't know about a number of studies. I know of a very well-done study that looked at hyaluronic acid and PRP together, and that seemed to be more effective, not astronomically more effective, but more effective than the treatments that we have. It's more effective, the combination of those two. But is it disease modifying? And that's the big maybe, because that's your question.
Yeah.
And there are studies that show it may be pushing off knee replacements for those patients. But I think this is where we still don't really know yet. But there's so much deceitful behavior out there with regards to stem cell therapy that the organizations involved and the FDA and the Federal Trade Commission and CMS are all trying to crack down on the problem of people advertising, come onto my clinic, I have stem cells, I will inject you, it's 100% guaranteed to help you, I'm going to give you new cartilage. And one of my colleagues at NYU did a study where they looked at 1,000 websites, and 94% of those websites who were promoting stem cell therapy were making inaccurate statements. And it just, engenders distrust between doctor and patient when you're going for a treatment and you think they're telling you something that... I had a friend, this is about 2 weeks ago, my close friend from high school sent me a brochure because he wanted to get an injection from his doctor of something like an umbilical cord or Wharton's jelly injection, which is not allowed. And I look at the brochure, I said, send it to me. And I made the bigger and I circled it. And on the brochure, because it's from the company sells it to the doctor gives it to the patient. On the brochure, it said, this is not intended to treat any condition. I was like, and I just circled it and I sent it back. He said, never mind.
Before we leave the hip, what is the role of cortisone as a treatment to delay the need for surgical intervention? Is it particularly efficacious, or do you not muck around with it?
I don't love it because we worry about what it's doing to the cartilage. Listen, I think because it's such a successful operation, I'm more apt to push for the hip replacement in the appropriate patient than a cortisone injection. Because satisfaction rate, 90-95% for hip replacement surgery with low complication rate. That's not to say that I don't do it or I wouldn't do it, because there's certain circumstances that I would. I would give hyaluronic acid in the hip also, although it's not FDA approved. It can be used off-label for that application. There's some studies to suggest that the gel can help, but we're still trying to figure out a better way. But we also know that if you give an injection right before hip replacement, there's an increased risk of infection. So we know that there's something about this that we need to be cautious about.
Anything else about the hip before we move down to the knee?
No, because I think even in the knee, we're going to be talking a little bit about the hip too.